Hi, my name is Dr. Ellen Storm and I am a middle grade SAS doctor in paediatrics and neonates, and this is a video for anybody who might be interested in the case of Lucy Letby. To give you a bit of background, in addition to my medical training, I also have a master's degree in public health and half a PhD, which I carried out looking at, or I became interested in, maybe let's put it that way, the relationship between science and society. And I was looking at particularly nutritional science and how we know the things we know. So I became interested in a branch of philosophy known as epistemology, and also a little bit logic, which is about how we actually reach the conclusions that we reach, particularly in relation to science, how we reach particular conclusions from certain sets of information or data, for example. And so that, I guess, and that has also been the subject of the book that I've written. The first half of volume 1 is published, and volume 2 I am working on, which is Diseases Have Causes, One Doctor's Journey with an Apple and a Pen. So that's the background to how I have come to be interested in this. And what I want to talk about now is my response to something that was posted on one of the Facebook forums recently, which was a table. And it was a table of the insulin and C-peptide values for babies F, L and Y, giving figures in picomoles per litre. Before I start, I want to point out that the information that I'm providing here, and I am reading it off my laptop screen partly, because that's essentially, this is going to be an audio transcript of what I've written, and I will be posting shortly on my blog, so you'll be able to read it there if you prefer reading. But I know a lot of people prefer to listen to things. I'm one of those people, like wander around doing the washing up with my headphones in. Okay, so I am going to read this, I think, now. Let's just begin. And I'm sorry if it gets a bit dry. It might be a bit long. I will try and go at a reasonable pace so you can take things in. So please note the information provided below, I'm about to speak, represents the current understanding and opinion of myself, Dr. Ellen Storm, on the 10th of March 2025, based on the information available to me at the time, and it does not represent the viewpoints of any organisations with which I am associated. Necessary disclaimer, right? Other specialists may wish to comment on and or clarify some of the points made below. I reserve the right to update my opinion based on the provision of further information in the future. So that means that if you know better than me, or you have an understanding, knowledge, access to a piece of data or information or a paper or an article or anything that maybe either contradicts or adds to or further explains something that I'm about to talk about, then I'm super happy to hear about that. I'm not here saying that this is absolutely the case. This is as far as I have got with this subject at the moment, and I would like to share it with you. So, the table, you will have to look on my blog for that. But just to explain what it says the insulin values for babies F, L and Y were 4, 6, 5, 7, 1099 and 6945 respectively, and the C-peptide values for babies F, L and Y were 169, 264 and 220, all picomoles per litre. So a couple of days ago I did a very brief literature search on something called Open Athens, and I just put in when I saw this, I just put in the terms C-peptide and neonate. I was kind of just being vaguely curious, I suppose, to see what would come up. So I would recommend that anyone who wanted to do anything with this information or take it forwards, do a full literature search to fully scope the data available on this subject. So this is in no way systematic. This is just what I have found over the last 48 hours and what I've come to understand, which I think it would be helpful for other people to understand too. So I've divided this into 3 questions, each with an answer and a conclusion. We'll go through them one at a time. Question 1. What is the likelihood that the observed values of C-peptide and insulin in picomoles per litre in babies FL and Y were all false positives? And that means that the true values were actually within the normal or reference range. So what that means is that we've seen a sort of aberrant out there value and it's wrong. Yeah, so their actual blood level at the time that that sample was taken was much lower for the insulin than the reading that we got. And there are explanations for why that might be. So, answer. Assuming the correct functioning of the assay, there will always be a degree of sampling variability within a range. So, for example, if you take 3 samples from the same patient at the same time and run them on the same machine, you will most likely get 3 different values. You're very unlikely to get the exact same result, although if it's a good test, they shouldn't be too far apart, but there will be some what we call sampling variability. So that will be up and down, but within a certain sort of range like this. And this range should be known for any population for whom an assay is to be applied as a screening or diagnostic test for any particular condition. And in this case, the condition that we're interested in is something called congenital hyperinsulinism, also known as CHI. And that range, it should be relatively narrow, because if your range is narrow, you have a more sensitive and specific test. So you have greater sensitivity and you have greater specificity. What that means is that greater sensitivity means that your test is more likely to accurately detect the condition if the condition is there. So that means you got it and you have the test to see if you've got it, and it gives you a correct positive diagnosis. Greater specificity means that it's more likely to accurately exclude the condition if it's not there. So that means you haven't got it, but you go for the test to get it, to see if you've got it rather, and it correctly identifies you as not having that test. That's specificity. And so if you have a wider range, your sensitivity and specificity will be lower, and you will be more likely to get things called false positives and false negatives. That means basically the test is wrong, and it either tells you have the condition when you don't have it, or you don't have it when you do. And every single screening and diagnostic test has these parameters attached to it, which should be known before that test is kind of put out there and starts to be used. So the other thing that you need to know about your test is something called the population reference range. So that's different from the range of the range of your sampling variability. That means that if you take 100 samples from 100 different people, you're going to get values again within a range. Okay, so the range of sampling variability is different from the population reference range, which should also be known for any assay that is to be used to screen for or diagnose a particular condition in a particular population. So the population reference range is derived by taking samples from a number of unaffected individuals who share similar characteristics. Now that's important. The characteristics are important. You have to define your population. So it might be adults, might be children aged 6 to 12. Might be babies, and if it's babies, there are different kinds of babies, so you need to say what their gestational age is if they're newborn babies. So for newborn babies, you need to know their gestational age, you need to know their birth weight, as sort of 2 basic things. So for premature babies, the reference range for any parameter is different depending on gestational age and birth weight. And then your reference ranges for children are different depending mainly on age. Also, for some things, gender. So before you start using your test, you have to clearly delineate your reference ranges by testing some healthy, who you believe to be healthy subjects, to find out what that range is. So then you take an average of your, if you've done 100 people, you take an average of those 100 values and you calculate the mean. And the reference range is usually something called 2 standard deviations about the mean. So that, what a standard deviation is, a measure of spread. If you have a range and you have a distribution, we call it a normal distribution curve. You have your mean in the middle. If things are equally sort of arranged around the mean, so to speak, then you can have things quite tightly arranged around your mean, like all of your values are really quite close to your mean, or you can have them quite spread out. And your standard deviation, 1 standard deviation, 2 standard deviations, if your mean is in the middle of your curve, tells you that, get this right, so 95% of results in a population of healthy individuals would be expected to lie inside that range. That's your 2 standard deviations, and 5%, 2.5 on each side, would be expected to fall outside. So you have your reference range. This is all normal healthy people who do not have your condition, and 5% of them are going to lie one side or the other of your upper and lower limits of normal. For insulin, for the test to accurately diagnose congenital hyperinsulinism, the reference ranges also need to take into account the blood sugar at the time of the test, because they should tell us what level of insulin might be expected for different blood sugar levels in infants who do not have the condition. So healthy infants, blood sugar varies. Your pancreas starts producing insulin in response as it goes up, produce more insulin, goes down, produce less insulin. And so there should be, you know, for any particular level of blood sugar, there's going to be a reference range around that. The combination of high and low blood sugar is suggestive of congenital high insulin, sorry. The combination of high insulin and low blood sugar is suggestive of congenital hyperinsulinism. Sorry. Okay, so you might expect to see, so those might give you like some values just sort of a bit outside the normal range. And we see that quite a lot, and we sort of go, it's sort of just 1 or 2 above or below, and we probably discount that as probably normal. If you see something that's really far outside, then the first thing I would normally think is that actually correct, or is that just a machine malfunction? So more extremely aberrant results might be expected to be seen as a result of assay malfunction or incorrect calibration. And calibration data for the assay at the time of testing would be necessary to confirm its reliability. I have no idea whether that exists for this in this case, but somebody might know. Please tell. So, if it is true that no data is available for the range of sampling variability, the sensitivity, specificity, and positive and negative predictive values of the tests, or the population reference ranges for both parameters for populations of preterm infants of different birth weights and gestational ages and at different levels of blood glucose, then it is not possible to answer this question, which we said at the beginning. So just to remind you, that question was, what is the likelihood that the observed values of C-peptide and insulin in babies FL and Y were all false positives, i.e. that the true values were actually within the normal or reference range. Point being that we haven't actually got a reference range that's relevant to that particular population. Okay, conclusion. If it is true that no data is available for the range of sampling variability, that's what I just said. For the range of sampling variability, the sensitivity, specificity and positive and negative predictive values of the tests or the population reference ranges for both parameters for populations of preterm infants at different birth weights and gestational ages, then this test should not be being used in a clinical setting for these populations of infants, as it is not possible to correctly interpret the results. And if it is being used in the clinical setting, it should be understood to be a guide only, and interpretation should be with caution and with the caveat that these reference ranges and values have not yet been established. Okay. Next question. How common is congenital hyperinsulinism in premature neonates? So, answer. According to Congenital Hyperinsulinism International, CHI affects 1 in 28,000 births and is the most frequent cause of severe persistent hypoglycemia in newborn babies and children. According to the CHI team at Alder Hey, hypoglycemia due to CHI is a relatively rare but potentially serious condition occurring soon after birth. The estimated incidence of CHI is 1 in every 40,000 to 50,000 children, so that's a much lower incidence, different estimate, although it is likely that the incidence is higher. However, according to the CHI team at Alder Hey again, there are different forms of CHI. These can often be distinguished by the length of treatment required and the infant's response to medical management. Some forms will resolve and are considered transient. Others arise from genetic defects and persist for life. These genetic forms of CHI do not go away, but in some cases may be easier to treat as the child gets older. At present, there are 9 known genetic causes of CHI, which can be inherited as an autosomal recessive or dominant, in an autosomal recessive or dominant manner. And then it just says what the genes are. According to the CHI team at Alder Hey, transient CHI, and transient CHI is what we're really interested in here, means that the increased insulin production is only present for a short duration. And critically important here, is found in conditions such as intrauterine growth retardation, babies with low birth weight, prematurity, infants of diabetic mothers, and infants with perinatal asphyxia, asphyxia being issues with low oxygen at birth. So transient hyperinsulinism can occur in infants with no predisposing factors. The mechanism causing this is currently unclear. Some of the transient forms of CHI will need treatment with medications for a few weeks to a few months, but generally will be able to come off treatment at a later date. This will be assessed by a fasting study while off all medications to prove that the hyperinsulinism has completely resolved. Okay. It is not clear from these sources whether or not the incidence figures given above, remind you, 1 in 28,000 or 1 in 40 to 50,000, include all cases of transient CHI, or whether they only refer to genetic CHI persisting into childhood. Therefore, the incidence including all cases of transient CHI may be higher. So, conclusion, it is not possible to be sure of the total incidence of CHI, including both genetic and all transient neonatal cases, based on the information available at the time of writing. Further information is required in order to answer this question, specifically whether or not any studies have been done to determine the incidence of hyperinsulinemia in premature neonates at different gestational ages. Failing that, as a more general guide, how frequently hyperinsulinism is generally found and treated in an average level 2 or 3 neonatal unit, so not the big tertiary neonatal units, might be helpful to know. Certainly for myself, it's something that crops up occasionally. We do have a guideline, and we do occasionally treat babies with higher concentrations of glucose or with glucagon. it's not common, but it does happen. So therefore, it is not currently possible to draw any conclusions as to whether or not 3 cases of CHI in 1 unit might be regarded as exceptional. Hard to say. Maybe they're a bit like buses, you know, like you don't see one for ages and then 3 come along at once. Question. Okay, moving on. Third and last, but I think the most important question. Always leave the most important one till last. How might we account for the observed values of C-peptide and insulin in babies F, L and Y if the obtained values are true, if A, the obtained values are true, i.e. they accurately reflect the true serum values at the time of sampling, and B, none of the babies received exogenous insulin immediately prior to that sampling. Yeah, like pretty much they were receiving it at the time or maybe in the hours beforehand. So, answer. Proinsulin is produced in the beta cells of the pancreas. Proinsulin is split into insulin and C-peptide, giving an initial 1-to-1 ratio. And standard teaching advises that endogenously produced hyperinsulinemia results in approximately equimolar concentrations of insulin and C-peptide. So that means if we measure your insulin and C-peptide in your blood, when you're producing it yourself with your own pancreas, you should have the same amounts of each. That's certainly what I was taught in medical school. It's the only thing I've ever heard in teaching since. Maybe I was just in the wrong place, but I don't know. It's standard. So whereas exogenous insulin administration produces a high level of insulin and a low level of C-peptide, because C-peptide is not present in synthetic human insulin analogues. However, and this is the point, this is actually incorrect in relation to babies and children. So the first paper I came across was one by Halliday, 1986, who reported on C-peptide levels in a case of transient neonatal diabetes starting on the 2nd day of life, and that paper stated that C-peptide levels in this baby were measured to aid in the assessment of insulin treatment, and very low levels were found for the first 5 months of life, less than 60 picomoles per litre. And then I found Nip and Ackerblom, 1981, who reported a study of insulin and C-peptide concentrations in 76 infants and children divided into 5 groups. So group 1 was a group of 20 babies, term babies, where they took blood from the cord at delivery. So that really reflected their levels in utero, or just before or around the time of delivery. Group 2 was 12 healthy term infants between 36 and 60 hours of age who had their insulin and C-peptide levels measured after 4 hours of fasting. Group 3 was 12 normal weight infants aged 0.5 to 12 months. They didn't actually say they were fasting, but all the others were fasting, so I'm going to presume that they were. Group 4 was 12 normal weight children aged 1.5 to 6 years who were fasted prior to elective surgery, and group 5 was 20 normal weight children aged 6.9 to 15.1 years who were fasted prior to elective surgery. And what they did was they calculated something called the molar ratio. So the molar ratio is the ratio of C-peptide to insulin. Now they used, slightly confusingly, different units. They used nanomoles per litre for C-peptide and milli international units per litre. I think that's what the M means, respectively, for the insulin, the international units per litre. So I went onto a conversion calculator, which gave me the opportunity to convert the international units per litre to picomoles per litre, and I did the same for the C-peptide as well. So they cited molar ratios, and then I worked out the molar ratios. which were different from the ones that they cited using different units slightly. But I'm just going to tell you what they were. So for the study, the molar ratios that they gave for group 1, 2, 3, 4, 5 respectively were 3.15, 2.95, 5.28, 4.90 and 5.23. So that means that the C-peptide was somewhere between 3 and 5 times higher than the insulin levels. And these were fasted samples, remember, so we would expect the insulin to be low. But the molar ratio was not 1. So immediately we've got something else going on there. We've got to explain it. When I worked it out in picomoles per litre for the 5 groups, the molar ratio came out at 2.53, 2.51, 4.38, 4.13 and 4.48. So notably, the group 2 babies between 36 and 60 hours of age had the lowest molar ratio, and then it increased after that with age. Okay, so the authors note that the molar ratio of C-peptide to insulin, what they call IRI, was lower in cord blood and neonates than in the older age groups, and that the fasting plasma C-peptide correlated in 56 children, excluding the cord blood, to the age of the children. So age went up, C-peptide went up. So they also note that the molar ratio of C-peptide to insulin is determined by the balance between the rates of removal for C-peptide and insulin. This is the important point. The kidney is the major site for C-peptide metabolism, whereas the liver is the primary organ of insulin degradation. The low molar ratio of C-peptide to insulin in 2-day-old infants could be explained by a diminished hepatic extraction of insulin in this age group. The relative excess of insulin in peripheral circulation in neonates being a consequence of decreased hepatic degradation could also explain why plasma insulin concentration correlates less well than C-peptide with the age of the children. The authors conclude that the hepatic extraction of insulin seems to be diminished in neonates, leading to a low molar ratio of C-peptide to insulin in the peripheral circulation. So, out of interest, I also calculated the molar ratios for babies F, L and Y based on the numbers in the table, and they came out as follows: 0.04, 0.24 and 0.03. So that's the other way round. In the study of healthy fasting babies and children, we have molar ratios that are more than 1. And in babies F, L and Y, who were not fasted, who were on presumably IV fluids and maybe had some IV dextrose boluses thrown in as well, and I'm afraid I don't know the details of all of those cases at the moment, they because they were not fasted and they had glucose being put into their system, that you'd expect their insulin to be higher because they would produce insulin in response to that. So it is notable that none of the cases, the ones that were more than 1 or the ones that were less than 1, none of them were 1. So we have to account for that. We have to explain why actually it's not the case that your body excretes equal amount, secretes, whatever, pancreas, equal amounts of insulin and C-peptide, and those equal amounts of insulin and C-peptide stay in the blood, and when you measure it sometime later you get equal values. That's not the case, because it depends on metabolism and excretion. And so the key point here is that insulin and C-peptide are handled completely differently by the body in terms of their elimination. insulin is largely very rapidly removed by first pass metabolism, whereas C-peptide is removed by the kidney. So it's excreted into the urine. It may also be, I think I saw something that said that it's actually metabolised within the renal cells as well. But I'm racing ahead of myself. I'm going to go back to reading my conclusion. It is notable that in none of the cases tabled above was the molar ratio found to be 1. The molar ratio of more than 1 in the healthy fasting subjects indicates a rate of insulin clearance higher than the rate of C-peptide clearance. This might be reasonable to expect in healthy subjects whose liver and kidneys are functioning normally. The short half-life and short duration of action of synthetic insulin is a function of its rapid first-pass metabolism by the liver. According to the British National Formulary, intravenous soluble insulin has a short half-life of only a few minutes, and its onset of action is instantaneous. Therefore, in healthy subjects, insulin is generally metabolised more rapidly than C-peptide. Nip and Ackerblom, 1981, identified reduced hepatic function in healthy neonates as a potential explanation for their observed differences, but they did not identify increased renal excretion. If insulin and C-peptide are produced by the pancreas in equimolar amounts, the only physiological explanation for a molar ratio other than 1 is differential rates of breakdown and or excretion. A molar ratio of less than 1, C-peptide less than insulin, can only be the result of the rate of renal excretion of C-peptide being higher than the rate of hepatic metabolism of insulin, and vice versa. Might this conceivably occur in sick premature neonates? So, C-peptide, or something called urinary C-peptide to creatinine ratio, is commonly measured in the urine of insulin-dependent diabetics to quantify their levels of endogenous insulin production. Therefore, C-peptide is not only metabolised by the kidney, but also renally excreted in the urine. Loss of protein in the urine, known as proteinuria, is a problem that affects premature infants due to the immaturity of their kidneys. So, and I found a paper by Triggerley et al. 2023, who tested 1,140 urine samples from 190 very preterm, and these were less than 31-week infants, in the first month of life for urinary protein to creatinine ratio. Now that's different from your urinary C-peptide to creatinine ratio, because C-peptide is a specific type of protein, or you can measure your total protein. And that's the ratio to creatinine, which is a measure of renal function. Okay, they found that preterm infants have physiological proteinuria and values of urine protein to creatinine ratio that are higher compared to full-term infants during the first week of life. And they go on to report that at the multivariate analysis, lower gestational age and increasing postnatal age, so how old they were the only variables significantly associated with higher urinary protein creatinine values. And there was also wide intra and inter-individual variability in urinary protein creatinine ratio, especially in infants with higher gestational age and clinical stability. So from this, we must conclude that it is physiologically plausible that sick preterm babies who have impaired hepatic and or renal function, specifically proteinuria, may have a molar ratio of less than 1. However, much more research is needed to accurately delineate this relationship, which is currently poorly understood. So I'm going to post that on my blog. I'll put the link down below so you can read it there if you want to take a bit more time with what I've just said and try to understand it. I'm very happy to answer any questions. as I say, this is kind of like, think of it as a work in progress rather than a definitive thing. Yeah, and we'll see how it evolves from here. So thank you for listening, and I'll see you soon.